I think we'll go ahead and get started. Thank you, everyone, for joining us. My name is Hamza Ejaz. I am the Rams Immediate Past President, and we have an expert panel today that will be talking about the workforce report, as well as some of the research articles that have come out over the last few years, guiding the medical students, how do we provide advice to the students for this topic, and how to become a little bit more informed so that we can figure out what the workforce entails for the next few years. So with that in mind, the agenda for the next 50 or so minutes is going to be brief introductions by the panel, followed by a journal club conversation regarding three main workforce articles that have come out in a few years. And then Dr. Cutright from the Executive Committee will be joining us to talk about how do we go about providing some of the advice regarding this issue to our students when we're talking to them about their futures. And then we'll also hopefully have time for a question and answer session towards the end. So if you have questions during the course, feel free to write them down in the chats, and then we'll address them with the panel during the Q&A session. And if not, you can raise your hand during the Q&A session and subsequently ask your question verbally as well. So thank you guys so much. I'll turn it over to Dr. Bennett to give a brief introduction of where you're currently practicing, your role within SAM, potentially your expertise within this subject matter.
Hi, good morning. I'm Chris Bennett. I'm an assistant professor of emergency medicine at Stanford University, former resident director on the SAM board, and also a prior member of the SAM Foundation Board of Trustees. I'm an epidemiologist and health services researcher.
Appreciate your time and being here. I'll go ahead and move on to Dr. Cutright. If you could please go ahead and introduce yourself.
Amy Cutright. I am an associate professor of emergency medicine at the University of Nebraska. I've been a clerkship director for 10 years and am in charge of all things student education in our department. I've been advising students at both Creighton and UNMC for that same period of time. Also, CDEM board executive member.
Thank you so much. And last but not least, Dr. Gettel.
Hey, y'all. Cameron Gettel. I'm assistant professor of emergency medicine at Yale School of Medicine. I do some work in geriatrics, health services research, looking at the workforce and costs and access to care, amongst other things. Also, I do some medical student resident work as well. Past a year or two, I've been a co-director of a thing here at Yale called the Yale Emergency Scholars Program, for those of you interested in research. So I sort of am in tune as well with what med students are thinking about. It's a combined 4-year residency and research fellowship as well, and engage with med students in that regard as well, advising them too. So happy to talk today.
I'll briefly introduce Dr. Courtney, who's not yet here, but hopefully should be soon. But he has chaired the SAM Workforce Committee. He's also one of the leading authors for the original 2030 Emergency Medicine Workforce Projections Report, as well as one of the leading authors of many of the studies that will be discussed today.
My name is Mark Courtney. I'm vice chair here at UT Southwestern in Dallas, Texas. Been here about 4 years. Before that, I was in Chicago and have had the pleasure of being the president of SAM and on the board and working with a lot of great people on the SAEM workforce, also working with a lot of great people from RAMS. So extraordinarily happy to do that. We're in the second year of the Workforce Committee, which is part of SAM. And I have been asked to talk with you a little bit about this particular article. I can pull up a few slides to walk you through this. It's an important article to go through a little bit of the narrative of how we've got to where we're at with investigating the workforce. Let me see if I might be able to share my screen here. There's a PowerPoint. All right, how are we there? Good. So this is basically just a synopsis of some of the data. Now, I was involved as a co-author on the original workforce paper that predicted that we would have 7,009 extra emergency physicians. I'm not happy with the way that ended up being messaged by social media, as well as readers of the article, as well as to some degree our professional organizations. It is what it is. It was a research study, and like all research studies, you have to dig into the details. And I'm going to do that a little bit briefly here because I really want to have discussion and allow time for the other presenters. I think this is one of the papers that has been most cited and most talked about, but least read. I wonder if many people have actually read the methods or the results. But it was a result of a good process where members of multiple organizations got together a long time ago before COVID and tried to guess, what does it look like for 2030? It was administratively led by ACEP, but also ABEM participated, IMRA, CORD, et cetera. So it was a group of folks to look at this. We looked at Medicare claims data, which we'll hear later from some presenters today as a way of thinking about who's seeing patients in emergency departments. It looked at the AMA master file, which is a data set to look at who are practicing emergency physicians. And then we also wanted to look at census data for the United States. We wanted to look at who's actually showing up to emergency departments and what those trends look like. And it was really just a modeling exercise. Modeling forces us to look at assumptions. And we basically just put assumptions into some mathematical formulas and generated some numbers. But it wasn't anything more than that. It was a guess at what could happen under different scenarios. We thought that in data that we were looking at, we're seeing about 15% of Medicare claims. We noted that the number of EM residents that were graduating had been increasing and increasing and increasing significantly from 2008 to what we were looking at. And again, we started this process before COVID. We looked at physician attrition, and we're going to dig into that a little bit more today, but noting that our data from 2012 to 2017 predicted a rate of attrition around 3 to 3.5%, meaning every year about 3 to 3.5% of the EM full-time workforce is bowing out and not coming back. This is just a slide showing what growth in residency spots looks like. And you can see here is where we were back at the 2020 era, looking at what that might look like with 4% growth, 2% growth, or no growth. We didn't know at the time what was for sure going to happen with number of residents and number of residencies, but we had been looking at residency numbers increasing. We weren't really sure what attrition was going to be, how that would be affected by COVID, financial markets, burnout, which even before COVID was a signal. Services provided by apps is difficult to be certain about because we know that they can be NEDs getting billed under the physician name, or they could be independently billing too. And we weren't sure about demand for services. It sure looked like it wasn't declining. We explored the possibility of novel service line growth for emergency medicine, but didn't include that in our modeling because there just hasn't been a ton of growth or a big coherent leadership push on what emergency medicine outside of traditional EM looks like. This is basically the numbers. And this is really important to understand that what we tried to present was some contingency tables and data for you to look at the assumptions and see what it might be. Now, nobody really did that. They just focused on what was labeled as the, quote, most likely scenario. And again, this is not my most likely scenario sitting here in front of you today, but it's what at the time of this report we thought was the most likely scenario. Again, pretty much before COVID. And this assumed that there would be 2% attrition to 2% EM growth. And let's go to the next slide. But this is important. And if you look at what would happen with 4% attrition, even still under 2% GME growth, there's a difference of 5,359 physicians there. So the important here is when you play around with this table and you look at it, you realize that just small changes in attrition can have big changes in the final numbers. If we had no GME growth and everything was flat, 3% attrition, which was our base scenario, would result in a difference of 1,000 physicians. So really subtle changes on these numbers would result in a lot of stuff. I think I'm going to skip over this largely, but just to mention, we don't know yet what's going on. This is the number of positions, and this is from a relatively recent article. And we can see that the number of positions is not exponentially rising, but it hasn't really gone down, despite the fact that the number of applicants certainly went down for the most recent match cycle. Now, what this number is going to do over here in the future, it's kind of TBD. But again, this was the balance of the most likely scenario from our report. We assumed that there might be a reduction in emergency visits, that there would be about 20% patients seen by an NP or a PA only independently billing. That resulted in this surplus number here of the 7,845. I think a lot of people would say that some of these assumptions right now we don't think are true. Even with COVID, we're not really seeing total visits going down. We're seeing our emergency departments still pretty clogged. And you might say, well, what if we reduce the number of patients seen by NPs? You still end up with a little bit of a surplus from our model. What if we ended up with 4% attrition? Wow, this is where it gets really interesting. So even if GME growth continued at 2%, but attrition was 4% over here, then the projected supply is a lot lower for 2030. The difference is there. And then we actually see here that there's a deficit. And so the point here is that changes in attrition can have a big compounding impact on what things might look like 10 years from now, or even if we extrapolate out further. So what are some questions I think still need to be answered really quick? What are the geographic distribution of the workforce and workforce change? What's unique about academic workforce? What does technology look like in terms of demand and supply, and what EM looks like? And then what's going on with attrition? And I think we're going to get into that now with some of the subsequent presenters. So I'm sorry for my delay. I tried to be pretty brief, but I think we can dig deeper into any of this stuff that you want. I've highlighted what I think are some of the big assumptions, some of which are obviously not the case. Looking at the data now, but what the future looks like, I think the rest of the presenters can give us a little bit more insight. So I appreciate the opportunity to talk to you all and you all spending some time with me today on this topic.
Thank you so much for that presentation, Dr. Cordy. This has been very informative. I'm sure the audience is going to have questions, as this is this was probably the first paper that came out regarding this topic more recently. If you have questions, please feel free to include them in the chat. And once we get to the Q&A part, we'll bring them up. I'll go ahead and turn the floor over to Dr. Bennett to discuss his research.
Thanks. Can we transition to my slides? So as advertised, I'm here at Stanford. My work has been to look at emergency physician workforces, both the overall workforce, how it is different by gender, but also looking at the residents and the residency programs within that workforce. Can you go to the next slide, please? And in particular, we're going to be talking about a paper of ours out in Annals that essentially looks at that. And next slide, please. The primary objectives were to take the work that we had done, looking at physicians overall, to expand and to understand more about the emergency medicine residents and the residency programs training them. And at the same time, also to comment on the differential aspects of geography, where residency programs were and the trends between those. Next slide. The paper reports two areas of interest using two different data sets. The resident physician population was essentially emergency physicians in the AMA master file, and I'll talk a little bit more about what that looks like, but it's essentially people who are in a national database of all physicians in the country, those who identify as residents. From the residency program perspective, we use data through direct requests from the ACGME, looking at their year for which they obtained their accreditation, the location, and also the primary training site, where residents when these programs were primarily getting the most of their clinical education. Next slide. And just sort of a framework, because the AMA master file is this sort of nebulous thing for a lot of folks, but you essentially are a physician in the AMA master file, and then you are listed and that information stays there. You get into the master file when you start medical school, or in the case of people who do medical school outside the country, when you enter into a US residency program, or if you do your residency program elsewhere, when you enter into clinical practice and obtain a medical license in any one of the states, or when you become certified or obtain certification through the American Board of Medical Specialties. Essentially, we were focusing on the residents. Next slide. What will be no surprise to any of you is I found a way to always include a map in every work, and this paper was no different. And essentially to say residents aren't geographically distributed homogeneously across the country. Next slide. There are a number of different characteristics. Overall, the majority of residents are people who identify as men or male, and that's something that we've seen in previous work, and that was something that continues to be a finding that is in all works related to the emergency. What you'll notice is that most residents, although they have similar ages and similar distributions, are geographically located in urban populations, higher density individuals, higher density communities, compared to small and rural areas of the country. Next slide. We know that the emergency physician workforce is growing. The residency programs training these physicians has increased over time. You can see that overall, the number of programs had been pretty stable for quite some time, but around 2014, 2015, the total number of programs increased quite dramatically. That's in part to two reasons. The first of which most of you are aware of, is the single accreditation system transition under the ACGME. And so these are osteopathic programs coming in under the fold of the ACGME, but it's also individual programs that are newly launched. Next slide. And when you think about these programs, this slide is not as intuitive to read. And so we'll just sort of say right here, what I'm trying to convey to you is that these new programs, in particular, these 3-year programs, are being added to areas that already have a higher density of programs. And if we go to the next slide to sort of put, again, sort of a visual map presentation forward, and if you look at the bottom, we go from 2013, 14, 15, 16, 17, and this will cycle through. Essentially to say there are a minority of states in the country that have the majority of programs. These states that already have programs are gaining more programs. So increasing density by darker blue, and the gold dots that you see popping on are new programs that are being added over time. There are areas of the country where you do not see physicians, you do not see residency programs, you do not see residents. That doesn't necessarily mean these are not population densities, just to say that new programs are being added to areas where programs already exist. Next slide. And so what we take away from this, sort of the big findings, are that the resident physician population is growing. Most of these residents are training in urban areas where there's dense underlying populations, which makes sense. A Component of the growth, as I mentioned, can be attributed to both the single accreditation system, but also a number of programs that are newer and entering into the workforce under ACGME accreditation. These programs tend to be in areas that are densely populated with already existing programs. The caveat is we know there are a number of finite resources to train resident physicians in the country. In particular, when you think about pediatric rotations, there are a finite number of pediatric emergency departments, pediatric facilities, and training opportunities. And so this creates a situation where if you have a city with 17 programs, they're all vying for the same training aspects. And so it creates this issue is with increasing densities, what are the educational resources to these programs? What are shared? What are missing? And how these programs account for potential issues with obtaining or meeting the core program requirements, which is work that we've also done, not this, but it sort of starts that conversation. Next slide. The work, as is the case with all the stuff that we do, has a number of limitations. The first of which is we were truthfully interested in residents and resident physicians within both the data sets. So we can't account for people that weren't included in that. The AMA master file is the gold standard for comparing physician workforces. But if you've just graduated from medical school and transition into residency, there's a lag. People take gap years. Sometimes information is not there in the setting of people removing their records. And so there is a degree of incompleteness that is there. We think it doesn't meaningfully impact the outcome, but that's always something we talk about. We also focused on programs that had ACGME accreditation. We know that there are a number of programs who lost accreditation and were closed during the period of study, but we didn't account for those with either probationary or preliminary accreditation. And that we also knowingly looked at primary training sites. We know, as the case with my residency program and where I am at faculty now, we have multiple training sites. And that's not to say that all these programs are in the same spot, but it's to say that predominantly where the bulk of the training occurs is in urban areas. There is always the potential for rural sites that were not accounted, which is an area that we think should be addressed in future studies. But the questions then become what next? So we have a lot of new residents that are now a lot of new doctors. And the question becomes, we know where these doctors are going. The question is, where are these doctors now? And we hope to know in the setting of post-COVID, where these physicians are practicing, and not just geographically by state, but from a region. Are they in areas that are densely populated versus not? Next slide. And at the end of the day, when you go into training and you leave, who's leaving and when? So better understanding whether COVID may have been associated with an increased rate of attrition overall, whether it may have hit either younger or older physicians, and also stratifying by both residency, training, board certification status, to understand who's sticking around and who's not, and how that's changed over time, mostly with regards to how that impacts access to emergency physician care across the country. And that's it, I think.
So much, Dr. Bennett. So you started to realize, hopefully, a theme. We see where the workforce projections came from. Dr. Bennett has talked about some of these deserts where the geographical densities are. Dr. Courtney alluded to some of the comments about attrition rates as well. So I'll turn it over to Dr. Gettel, who will talk a little bit more about some of that research.
Great. Thanks, Hamza. All right. So Mark and Chris really set me up, which is wonderful. Mark, I feel like the forecasting and predicting surplus or shortage is really hard, and you're damned if you do, you're damned if you don't kind of thing. It's sort of hard to hit that nail on the head. And one of the things that I sort of have thought about as that paper came out, and then sort of this paper here, and then other ones are, the outcome from that paper was, hey, there's the surplus. Well, that's going to impact medical students considering emergency medicine resident and that outcome, and then that's one of the inputs for the formula. So it sort of is all interlinked and cyclical. And it's really difficult, the fact that the forecasting hadn't. So that's sort of one of the things I wanted to bring up. Chris shared some of the densities for residencies, and I'm going to share some as well for emergency physicians as well. So much of this is supply and demand, and I think my main message is the sky is not falling, and I'll share some thoughts about that at the end if we have time. I have some slides at the end about sort of advising medical students, but I want to get to Dr. Cutright as well. So we did the study published in mid to late 2022. It was in response to the study that Mark mentioned about the surplus. Our hypothesis was, I was talking to people on shift, my colleagues, and they were leaving emergency medicine. There was COVID stress and all these things, and balancing life, personal and professional, and maybe that attrition rate was an underestimation. That was our hypothesis going into it. We published this, and our objectives were describe the longitudinal entry and attrition of emergency physicians, non-emergency physicians, and advanced practice providers in the ED setting. We had data pre-COVID, and then compare the proportions of emergency clinicians by rurality, and also look at some state level differences in density. We used publicly available Medicare data 2013 to 2019. We linked to American Community Survey data, which had population estimates by state, calculated densities. And we included clinicians if they were reimbursed at least 50 times for emergency department care. And so that's a relatively low bar to meet. You can imagine a few weeks in the ED, and you've definitely met that in the way of Medicare fee-for-service beneficiaries. This was consistent with prior Mark's article. The Marco et al. Also used 50 as well. And these are emergency department services. So the data source we had was an NPI, a physician had 200 ED level 4 billing codes, 992 for that year, and they had 500 for 99285. Their total simple numbers was 700 for the year. If they had at least 50, then they were in the workforce for that year. So every year for every NPI, we said, how many services did the provider provide, and were they in the workforce or not? Was there evidence that they performed clinical services? And so then just a few definitions. We had that list of that wide data set, if you will, of every physician and if they were in the data set. And then we said, for each year, were they in the data set? Did they leave or did they newly enter? We classified clinicians as entering brand new if they were not identified in any of the preceding years. So say they were not in the data set in 2013, 14, 15, but then all of a sudden then they started to perform clinical services in 2016. They were identified in 2016 as entering brand new. So these are like graduating residents, as you can imagine. Re-entering were those that were in 2013, left in 2014, were out, were doing something else for whatever reason in 2015 and 2016, and then they came back in 2017. And so they would have been identified as re-entering in 2017. Permanent attrition are those that were in the data set and then left and were not identified again in the data set. So say they left in 2015, they were not in 2016 through 2019. These are example of retiring clinicians or somebody moving on to a different kind of clinical environment or whatever else they were going to do post emergency department clinical care. And so they would have been identified as permanent attrition within that year. And then temporary attrition is that same example that I had earlier. Well, in 2015, that person who left and came back, they would have been identified as temporary attrition. So some of our results, Chris had a Sankey diagram. It's a good visualization here. Each year you can see the blue vertical bar are the number of emergency physicians in the workforce within that year. And then the offshoots of TA, those that exhibited temporary attrition that year, PA, those that exhibited permanent attrition, RE, those that re-enter that year, that came back into the workforce. They were in 2013, they were out 2014, they came back in 2015. There, brand new BN. And so you can see the splits there. And then that sort of allowed us to calculate proportions of who exhibited temporary or permanent attrition. And then just bigger context, the composition of the workforce is at the bottom and sort of the launch trends of that. You can see APPs are sort of understandably going up, relatively consider about 5,000 there, a pretty good relative increase for their starting there in 2013. So making up about 26% of the workforce, and EM physicians making up about 2/3. And then over those years, temporary attrition annually was about 0.8 to about 1.5%, and permanent attrition was about 4 to 5% sort of throughout all the years it ranged from. And this is just a figure here looking at, Chris has talked a little bit about rural and urban. And so on the left are rural, on the right are urban clinicians. And the y-axis there are the number of clinicians. So you can see there's less rural clinicians and there's more urban clinicians. But you can see the proportional split here. Blue is emergency physicians, purple are non-EM physicians, and pink are APPs. And by 2019, EM physicians actually make up less than half of emergency clinicians within rural areas. And so as you may be aware, non-EM physicians moonlighting in the ED or sort of doing some part of their practice as more commonality in rural settings are contributing a good amount of emergency care, as are APPs, going up considerably in rural areas. And you can see that proportional increase as well in urban areas as well. It's not unique to rural areas, but emergency medicine physicians hold about 70% of the clinician volume within urban designations. This is just to orient you. This is meant to show the change of emergency physician density from 2013 to 2019. The colors on the graph show the density quintiles in 2013. And you can see the lowest density states, the 10 lowest density states are in purple, and the most emergency physicians per population are in yellow. The number on top of those states is the net percent change over those 6-7 study years. And so you can see states like Montana, South Dakota, Nebraska, they were in the lowest physician density in 2013, and they had a sizable increase over the study years. So that's sort of what you would want in the way of supply and demand. You would want those physicians going to those areas that really need it in the way of density. But then you can see states like Nevada and Idaho, very low and still even getting lower. They actually had a decrease in the density. And so that's concerning. And then conversely, you look at states like Pennsylvania, Massachusetts, Rhode Island, they already are in the top 20% in 2013, and they still saw a pretty sizable increase in the net change up until 2019, on the order of 20 more percent, a greater physician density. And so it's all about right sizing where physicians should go and incentivizing them, which is easier said than done to get physicians to the areas that need to be. Some limitations with Medicare data. It's difficult to capture some services billed by APPs. If they're practicing under a physician, that service is going to be under the physician supervision. And so it actually may underestimate the role that APPs play. These may be more conservative estimates, but I think most APPs were captured in the data set providing services. This wasn't a clinical encounter analysis. And so I think we caught the majority. There is obviously an inherent limitation with any kind of finite time period study. If you're defining permanent attrition not being in the data set, say somebody left in 2017 and then they were not in the data set in 2018 or 2019, well, what if they returned in 2020? And that's just sort of one of the limitations of the data set. We only have X amount of years, but we did do some 3-year attrition sensitivity analysis, and that did confirm our findings about the proportions that did leave, even with that stricter requirement for 3 years of attrition as opposed to just 1. Few discussion points. APPs make up an increasing proportion of the workforce. We're seeing approximately 5 to 5.5% of EM physicians leave in some capacity annually estimated. And that's a discussion for a bigger discussion about, are there stressors in the emergency medicine space setting that we can influence? Is that number appropriate? Are they doing other things? I'm not making judgment on that right now, but it was greater than the assumptions that Mark had presented. EM physicians also comprise less than half of the rural EM workforce. There's a lot of state level variability. Hope is that this informs decisions regarding residency training, APP utilization, and clinician employment. I have some slides here. In the essence of time, I'll stop there. And if we have some time at the end, I can come back to these. But thanks for having me.
Thank you so much for that, Gettel. So at this point in our discussion, I'll turn it over to Dr. Cutright. She serves, as she mentioned earlier, on the executive committee for CDEM, the Clerkship Directors of Emergency Medicine. Hopefully we'll touch on how do we go about it now in the context of this research, how do we go about advising our students about, hey, is there a spot for residency? Is there a job for you after residency? Ultimately, that's the goal, is to get a job, and ideally a desirable job in where you want to practice and how you want to practice. So if you could now walk us through a little bit more about providing some of that advice to our students from the CDEM's perspective.
Absolutely. So the perspective of the board on this, and in my own personal experience in advising students in these areas, is the best thing to be is honest. The most accurate statement I've heard so far from everybody is the sky is not falling, which is absolutely true. This is rapidly evolving over time. We've seen attrition rates even change in the last year or two, which is probably a blip post-COVID, and then is going to even out. But with evolving numbers of students going into emergency medicine, some of the training sites changing in the last couple of years as well, things are going to change a whole lot over the next few years. And so we're going to have to monitor and see what happens ultimately. The party line to medical students, number one, they are getting their data from a lot of sources that is deeply inaccurate. As Dr. Courtney stated, a lot of people heard about the workforce study like on social media as a headline and didn't dig into the study at all or look at numbers to understand the data behind it. From an advising standpoint, number one, please try and get accurate information about the EM workforce studies that have been done to the students early. A lot of times they're hearing about this in clinical realms from advisors and other specialties who are like, oh, well, you're just in emergency medicine. Are you sure you're going to even be able to get a job? And the answer is yes, overwhelmingly likely you're going to be able to get a job. There might not be your ideal job right out of residency. You might have to wait a little bit to get to a specific location if that's what you're targeting. But yes, you're going to be able to get a job. I think the experience of most advisors in emergency medicine would bear that out over the last couple of years. So number one, get accurate data in front of the medical students as early as possible, utilizing interest groups, forwarding emails about meetings that are put together by RAMS, SAEM, EMRA, et cetera, about this topic to medical students that are interested so they can actually hear from us as the specialty about this issue as opposed to other people who don't know it as much in depth. For current residents and medical students, a lot of what I tell them is it sort of depends on what you want to do. We had some initial geographic data from a workforce study that came out about 2 years before Dr. Courtney's study came out that looked at workforce study at a little bit more of a regional perspective. There is a large dearth of emergency medicine providers, especially in the Midwest area, as been backed up by some of the maps that they showed earlier, where jobs are consistently available. And so a lot of the conversations I've had with students is, Where do you want to work? So location, number one. What type of job do you want to have? Is it community? Is it academic? Is it something fellowship trained where you're working part-time as an EM clinician and doing something else, administrative or else otherwise? And then how much do you get paid? If you are targeting an area that's very densely populated with EM physicians, you get to pick one of those variables and the other two get predetermined for you. If you're in an area that's less densely populated by emergency physicians, you probably get to choose two of those variables and the third one's predetermined. The other thing I also tell medical students is they need to look very closely at the support that a residency program provides to them to help find jobs. So what is the networking capability of the residency? Where have they placed their residents with jobs historically in the last 5 to 10 years? And what resources do they offer to you to help support you in a job search? These are really great questions students can ask of residency programs during the interview process. My final piece of advice to students is if they have particular things they're trying to meet with a job search, that they probably start their search a little bit earlier because the job market is a little bit tighter than it was 10 years ago. This is a fact, but it's not so tight that they're not going to find a job. They're just going to have to look for the job a little bit harder. And it is likely that the job that they get right out of residency might not be 100% their dream job. They might have to do something not quite as ideal as what they want for a year or two, build some experience, develop your reputation as a physician amongst other EM providers in the area, and then transition to your target job after a couple of years if that's what you're interested in doing. So those are the main points that I make in advising medical students who are asking questions about this. For more specific questions, I tend to break out the actual data tables from some of the articles and show them the information related to that. In fact, Dr. Courtney's paper was super helpful for me because we looked at a couple of different options of, hey, well, what if more physicians leave because of COVID? What would that make the numbers look like? Would we be in a deficit or a surplus of physicians? And then things rapidly change. And so that comes back to my original point of please get data in front of the students as early as possible. There's been a bunch of things popping into the chat. So I'm going to pause here real quick to take a look at some of the questions here.
Dr. Cutright, thank you so much.
Yes.
We're approaching the end of the webinar, so I'll open the forum for questions and answers. So feel free to please, for the audience members, to please type in the chat your questions or just unmute yourself and please ask the question. I'll open it up both for Dr. Cutright as well as the rest of the panel here. Larger, more of a philosophical question, I guess, to some extent, but like what can emergency medicine organizations such as SAM, RAMS, ASAP, we have so many different representation. What can we do as an organization or multiple organizations to move the needle on this topic so that we are doing the best to assure that there are jobs for our residents and trainees and that there are jobs that they ideally want?
Let's see here. I see a question in here from Dr. Lewis. Do you want me to answer that one first or?
Yes, let's get that one first.
I'll take a stab at this one here. Do you know of any EM career advisors who have dissuaded students from entering the EM, given the recent workforce projects? And the answer is no, I do not know of any advisors that have dissuaded students from entering emergency medicine. About the only thing I can say that I have heard from some other advisors, if there's a student who is equally considering multiple specialties or is waffling on emergency medicine versus something else, I am honest with them about the workforce projections, if that impacts their decision at all. If they are not sure, but if they're committed to EM, then my response to them is we will figure out your job and that should not dissuade you from entering the workforce. To my knowledge, there is no actual data on that. If advisors are telling students not to go into EM one way or the other, there's no data on that I'm aware of. They suspect that this information about the workforce study is coming from non-EM career advisors, which is accurate. It's correct. Has there been anything done outside of EM? Formally, not to my knowledge. It's hard because we can't control some of the other specialists. I directly appealed to the dean's office at my College of Medicine and asked them to please forward any workforce questions to me to answer in detail, which has actually been very effective. For me, through the College of Medicine, I've had students reach out to me and have meetings with me about workforce study questions, which has offset a lot of student complaints. I've also brought it up at multiple interest group meetings for emergency medicine, which I think helps. I cannot dissuade like the random internal medicine like preceptor who has comments. That one I don't know how to control. I'd be open to ideas from the group.
Yeah, I've got a couple thoughts on that to be brief, and then we can kind of continue with some additional questions, but the SAM Workforce Committee has looked at this, and we've had a discussion with the SAM board and the RAMS board. My personal opinion is that there are some things that are intrinsic to emergency medicine that you find out while you're rotating as a student in emergency medicine that are either going to attract you to that field or distract you from the field. And some of that is the way it is. We're doing a little bit of qualitative research right now in our committee to try to explore some themes. Some of them are not surprising. It's, gee, I found out I'd have to work nights and weekends and that kind of stuff. To another student, that is an appealing process because it allows them to titrate some work-life balance and to schedule things when they want to schedule things and balance their clinical shifts around their life. The interesting thing is that used to be a very unique aspect of emergency medicine, and now it's not as much a unique aspect of emergency medicine. When you see hospitalists, you see laborists, you see critical care doctors, anesthesiology doctors working shifts, maybe 12-hour shifts and a little bit of a different flavor than what we experience. But some of the uniqueness of emergency medicine 10, 15, 20 years ago are really not 100% unique to emergency medicine as much as they used to be in terms of some of those things. So I'm of the opinion that we're not going to out brochure our way to the future. We're not going to simply create some document to share with some deans and the chair of internal medicine at institutions and try to convince them how awesome we are. That isn't going to be the solution. Probably the best solution is the individual relationships that students experience when they're working on shift. Sometimes they're going to experience highly motivated, engaged preceptors, mentors, and residents, and sometimes they're not. Sometimes they're going to experience flat people who are just trying to get through their day. And so we have to think about what folks are experiencing and what emergency medicine appears to be to somebody who is a medical student rotating and getting a first glimpse at what this field looks like.
Can I add to your question, Hamza, a little bit, just as my slides? I think it addresses a few of those things, and maybe a few of things in the chat too. And so you asked about what can SAM do, and I think it's a few things. I mean, Mark sort of mentioned it. It's like setting medical students up for success, for them to be able to see their future in the long term. It's about using the data that we found and providing them with resources. And so there's a lot of macro forces. We saw the match in 2023. Medical students see us. There's a great article by Brianne Jacobs in Academic EM about the struggles that we deal with in the way of record level boarding in hallways. Perhaps this year's match results in some way reflects our students' consideration that what they can see in our departments is not the way they want to practice medicine. So it does, I mean, it's advocacy at the national level, which we're continuing to do. It's advocacy at the institutional level. But I think some of the messaging also should be that this kind of thing like ebbs and flows. There's a lot of anesthesia, radiology, oncology did this not too long ago, just a few years ago. Anesthesia did this in the mid 90s, I think it was. Their match rate nadered at like 35% one or two of the years, obviously much lower than us, but it bounced back. I think it's just with time, if there are unfilled positions, there's actually a great piece from Jillian Schmitz and Zach Giroux in Annals in response to that piece was, and I don't have the right answer for this, but it was perhaps we need to accept that the number of EM applicants today is indeed the right demand, and we need to let market forces prevail and allow some programs to go and fill it. So I don't have the right answer to that, but it's just sort of a thought-provoking statement from them. Brian Carmody on Twitter does a lot of really good stuff about the match, and one of the winners is his preliminary data from AAMC for the upcoming for this cycle here. You can see on the green line, the total applicants to EM rebounded about 1,000, about 33%. And I think one of his points was about 80 to 90% were DO and IMG applicants. Obviously too early to tell what that means. And I'm not here to necessarily drill down at what that means there, but just sort of a little bit of data that we probably share with this cycle and next cycle. And then Hamza, your question about what can organizations do? I mean, I think EMRA, CORE, they've done a lot of great stuff. Their student advising guide, which has some really great chapters for medical students. SAM communities are wonderful. I've benefited from them as a later resident. Medical students getting involved with them can talk with people that are in academic medicine and sort of see what they do, how they craft their life, and see a long-term plan. Promotes longevity, prevents retention, that attrition kind of thing. And last, I'll say RAMS roadmaps are really great. If you're interested in emergency medicine and like research, or emergency medicine and health policy, emergency medicine and critical care, and you want to know and you haven't come across these yet, take a look at these. It's really great about like wherever you are in the process, early med students, later med student, early resident, later resident, like what opportunities you can and should be considering and sort of set yourself up for success. Like Dr. Cutright mentioned, when you do get to the back end and you're looking for a job on the years down the road, you've set yourself up for success and you become a brand, if you will. I'll stop there and let, some of these points are just what Dr. Cutright said.
The number of applications to emergency medicine is up this year. I'm going to put a great big asterisk on that number though, and say we need to wait for the match data on that. So the answer is we don't know yet. We need to wait for match data to actually see if that number demonstrates a true increase in interest in emergency medicine or something different. But many other specialties do not fill every single year, and they do just fine. So this whole idea that because we're not filling, it's a catastrophe is also not accurate. Ultimately, what it means is there's been a power shift that has shifted the power back towards the students, away from the residency programs, and change is uncomfortable. It'll just be interesting to see for the next 5 to 10 years what that looks like. Dr. Martin, I don't know if that answered your question on the numbers.
It did help me, although I almost feel like we should at least have a comparable number like we're displaying now in terms of people who are putting it on their list this year compared to last year, even pre-match. So I was just looking for some comparison data, since we were last year touting numbers that about 800 less US grads went into emergency medicine. I just want to thank all of you for talking about this advising, because I think so many people brought up so many great points. This is my 36th year in practice, and I've been a program director for over 30 years. And I got to tell you, I had an ophthalmology attending who was a chair, he was an associate dean, and he pulled me aside one time, ended up leaving both those things after 10 years. Not that many people do that for chairs in our specialty. So anyway, he didn't leave. He went back and he said, I really wanted to go back. I knew I was going to do this stuff for 10 years and go back to what I love, seeing patients in the clinic and doing procedures. And I don't know that we look at what we do in the ED like that, particularly with some of the things that Dr. Gettel and others mentioned with the boarding and things like that. This was brought up in the town hall a lot too, is that mentorship that students and learners are getting from us in that environment could be more positive. And that's the work environment. A lot of it is up to all of us to correct that. But thanks for the input on that. I appreciate it.
With the last few moments we have for this webinar, I want to poll the panel here. So we've had a slew of research that's come out in the last few years on this topic, and COVID has impacted a lot of these variables that are being considered. So what are some future directions? Is there, either for a workforce committee perspective or these different organizations that are working on this, is there another study or another reanalysis of updated data now that we're post-pandemic, to some extent, what the layout looks like now, and potentially updated projections, and where are we in that process?
Yeah, I've been pushing for periodic standardized ways of doing workforce measurement. Chris, Cameron, and I are thinking about what that might look like. We're probably going to be doing that ideally within the context of the SAM Workforce Committee, but there's different ways and approaches to doing that. My personal opinion is our field should not have different methods looking at the same big question in a haphazard way, periodically here and there, whenever people decide to kind of do it. And that should be done in a way that we can do it sort of in a similar fashion to look at trends over time. That being said, it's not perfect. There's limitations to all of this. We're going to probably have a little bit of a focus on also just the academic component of workforce, because we're seeing a pretty large number of people that are affiliated with some form of academic emergency medicine. And I think from a burnout, well-being, meaning, purpose standpoint, an awful lot of people probably on this call are interested in that. So I think that's going to increasingly be an important thing. And then finally, I think we need more measurement on what emergency medicine care really looks like beyond the emergency department. Everyone will say telehealth, but really we're looking to the next generation or two of emergency medicine leaders, people, innovators, researchers, innovative clinicians to kind of help lead us into that, because I think it is going to have to evolve beyond just what you experience in the physical confines of an emergency department. So that's going from micro to macro.
I feel like when we look at attrition from the workforce, it's a U distribution in terms of the hazard of attrition, both right out of residency and then at the end of 30, 35 years in practice. A lot of people left a lot of specialties. Emergency medicine was likely disproportionately impacted for a lot of reasons. And so I think it's important to understand that people are leaving the workforce for a lot of reasons. And what does that mean? Because if you leave the workforce when you're 35 compared to 65, that's 30 years of emergency physician care that would not have been addressed elsewhere. And so that's going to change assumptions. And it's also important to recognize the way in which healthcare is being delivered in the US is predominantly in the emergency department. So more and more acute, unscheduled primary preventive care is being delivered by us. We're doing the primary care that isn't being addressed elsewhere. And so I think the job description has shifted. Our transition is going to essentially result in a need for additional people into the workforce. the area component to it, the geography is going to be key to any study. And I know that everyone talks about the role that I think you, Dr. Cutright, were mentioning the stuff that we did in 2020, showing from North Dakota down to Texas, there are no emergency doctors in many counties. And in particular, some states where it's a handful of doctors providing the bulk of emergency care. And these are people who are self-identified as emergency doctors. These aren't necessarily people who are residency trained or board certified, but they're doing it. They have been doing it. Those people are retiring. They were the retirement age before COVID. And so likelihood is they're gone. And so the reality is what happens in that vacuum if we don't start providing care there? And I think that's the next question. Who's staffing the emergency departments in these counties and states?
For me, I'm actively looking at it right now, trying to, after this, then we published a piece in Academic EM about differences in age at attrition between men and women emergency physicians, and we saw some pretty stark differences with women. And so we're looking at that. That's one of the areas that I'm looking at actively right now. Is, does that occur across specialties? Is emergency medicine unique? And early phases of data management, but my very prelim data is suggesting that emergency medicine is not unique in that regard. It's a more global problem, which bodes well for emergency medicine, but does not bode well for the broader healthcare system. Qualitative work, Mark said he's doing some of that. I think that's great. And then academic, sort of, is academia protective to attrition, those kind of things as well, to sort of staying in the workforce. Do APPs, there's a conversation in the chat, do APPs leave the workforce? Is there churn, which we all see on shift, at least I do. A few of the things I'm thinking about. Welcome to other ideas, though, if anybody has other ones.
Thank you all for sharing your thoughts. I think we're just about at the end of the hour. So for the audience, thank you all for attending and partaking in this conversation. And for the panelists, thank you for sharing your expertise and for your dedication for everything we've talked about for the past hour. Also, just as a reminder, we have linked the articles in the chat that we covered today. There's been other articles that have come out since then as well. So please feel free to reference those as you're advising students. This webinar is also recorded and should be posted on the SAM's website shortly. So please, if you'd like to share this with the students as well as to produce, that's helpful as well. SAM Pulse also is our newsletter, and we had an article come out about summarizing a lot of these articles in a more abridged written format. And then there's also, over the last week or so, there's been on Twitter or X, whatever it's called these days, we've had tweetorials essentially breaking down the research in the journal club format for these articles. So whatever format is best catered to your students and advisees, please feel free to share this information with them and peruse it at your leisure as well. Once again, thanks everyone. Appreciate your time. Have a great evening.